Assalamu alaikum. So we'll go to the placental pathology, ectopic pregnancy, and trophoblastic diseases. You know, most of these topics actually, most of them are mainly clinical. So what we're gonna do, we're just gonna touch on the pathology part of these entities. So just the pathology part. The placenta is related diseases are really important because it imposes a lot of risk for both the mother and the child. So placental disease is clinically very important. It's a very unique structure. It has two separate vascular supplies from two genetically distinct individuals, the mom and the baby. Let's remember the average weight for the placenta. Usually the weight is around 500 grams. Remember this number. So around 500 grams. The lifespan for this specific organ, as you know, is very limited. So there is no organ with such an expired lifespan other than the placenta. So the lifespan, it's very well known. It's about 40 weeks. It's the largest organ in the developing fetus. The largest organ in the developing fetus is the placenta. We have the placental disc, umbilical cord, and the membrane. So three components: disc, membrane, umbilical cord. The discoidal organ has two services. We have the service facing the fetus and the other facing the mother. So we have fetal and or the coronary service and the other service. So two services, one facing the mom and the other facing the fetus. We have the amniotic fluid within the sac that support the fetus. We have the membrane that composed of amnion and chorion. So both amnion and chorion for the membranes. It's so important to know where is the chorion, where is the amnion. So we have fetal service, we have the maternal service. Remember, the maternal service is the one that facing the uterus, which is composed of the residual. That's why we call the residual service. So we have the chorionic service and the maternal residual service. Blood supply to the placenta into two umbilical arteries and one umbilical vein. So one umbilical vein, two umbilical arteries. So important in the umbilical cord. Whenever we examine the placenta, we need to take important suctions from the umbilical cord. It's so important to confirm the presence of three blood vessels. So we cut the umbilical cord and confirm the presence of three blood vessels. Why it's important? Because the absence of the three blood vessels many times mean a lot, mean some embryologic abnormalities. Like if we find two umbilical artery, we say we have two umbilical arteries, then they need to check about other really important abnormalities. So umbilical cord, remember, it has to have three blood vessels. Decidua forms the border between the fetus. It's between the fetus. You know, it's kind of part of the endometrium which is progressing or developing to face the placenta and prepare the service that's important for implantation, the residual. Remember the coordinates of the villas, or the major important component of the disc, of the placental disc, is the chorionic villi. So the most important component in the chorionic disc is the chorionic villi. The villi is composed or outlined by cells. These cells are cytotrophoblast or syncytial trophoblast. It's These are very important cells that secrete the epithelial CG, especially the syncytial trophoblast. So this is the chorionic these are the residua. Here's the membrane. You see the amnion and the chorion, the umbilical cord, and so on. So these are the chorion villi. This is the umbilical disc, the chorionic disc. Umbilical cord. You see that it's outlined by the membranes. This is the umbilical cord, and this is the other face that is facing the mother. So the residua is here. Umbilical cord and the fetus supposed to be on this side. As I said, most of the placental disease actually are the so-called important pathologic entities in the placenta. And we start with the inflammation. The inflammation and infections, we have two paths for placental infection. It's so important to recognize that two paths. We have the one that ascending through the canal itself, the birth canal itself, and the one that comes from the hematogenous. So two inlets for inflammation, either the canal itself or from the hematogenous separate. So ascending infections are the most common ones. So the ones are ascending from the canal are the most common one. Most of the majority of infections actually are bacterial. So most infections in the placental disc are ascending, coming from the canal, and these infections mainly bacterial. Can be mycoplasma and candida, but mainly bacterial. So most of the time we check or look for the bacteria. So how can we check these inflammation? You see the membranes. So there's inflammation, acute inflammation of the membranes, the discoloration of the membranes, discoloration of the amniotic fluid. We examine the amniotic fluid, we examine the placental disc, we examine the umbilical cord, we examine the membranes looking for inflammatory infiltrates. So usually if there is inflammation, the amniotic fluid, usually if it's bacteria, usually it's cloudy with some turbulent exudate if it's bacteria. Histologically, it's so important to confirm the presence or absence of the inflammation. It's so important to look at the membranes. Membranes are essential in the definitive diagnosis for inflammation. Actually, most of the time, inflammation in the placenta, most of the time seen in the membranes. Sometimes, many times actually, not sometimes, we see it also in the umbilical cord. Rarely we see it in the chorionic villi. So how to confirm the presence of infection, of inflammation? It's mainly by examining the membranes, umbilical cord, and the chorionic villi. Where we can find the confirmation, most of the time the confirmation is seen in the membranes. We see acute inflammatory infiltrate in the amnion. This is the amnion. So this is the amnion and this is the chorion. So we see acute inflammatory infiltrate. These are all neutrophils in the amnion and in the chorion. Mainly in the amnion. If we don't see it in the amnion, the inflammation or the acute inflammatory process is not that confirmed. So we need to see it in the amnion. We take suctions from the umbilical cord. We see what we call inflammatory infiltrate within the blood vessels, vasculites, kind of vasculites, neutrophils, and so on. That's what we call phenycytes. Phenycytes mean inflammation in the umbilical cord. So confirmation of inflammation in the placenta seen usually normally in the umbilical cord and mainly in the membranes. Where we look at it, we look at it in the membranes. That's why they send the placenta into histopathology examination. Why they send it? Most of the time they send it to confirm the presence or absence of three umbilical cord blood vessels. That's what we see. Check for inflammation in the chorionic villi most of the time. we don't see. What we see usually is the inflammation in the membranes. We said uncommonly, most commonly it's coming from the canal, the inflammation. Sometimes it's coming from the hematogenous separate. When it's coming from the hematogenous separate, most of the time the infection, the inflammation, the change seen in the chorionic villi itself. So the placental villi are the ones that are really involved if the inflammation coming from the hematogenous. Most of the time, transplacental infection that's coming into the placenta can affect the fetus, and many times it gives rise to what we call the torch syndrome or the torch entity that including the toxoplasmosis. These are the etiologies actually for the torch. Toxoplasmosis, syphilis, and morbella cytomegalovirus, and so on. This is what we see in the placenta. If it's hematogenous, we check the placenta the placental villi. We see the acute inflammation in the placenta itself. Ectopic pregnancy, by definition, we've seen by definition is the implantation outside of the uterus cavity. Any implantation outside of the uterus cavity, we call it ectopic pregnancy. Most of the time, majority of ectopic pregnancy actually are seen here in the tubal. So we call it tubal pregnancy in 95% of the cases. So most of the cases of ectopic pregnancy actually seen in the fallopian tube. It can be seen in the ovary, can be seen in the peritoneal cervix. These are the most common site for ectopic pregnancy: tube, ovary, and in the peritoneum. So these are the common sites. The clinical features, many times it presents with bleeding, abdominal pain, amenorrhea, and so on. We go through this in the clinical. How we diagnose it? Diagnosed by combination of the clinical, the ultrasound, with the CT levels, and so on. In the microscopy, which is the most important part, to confirm the presence of ectopic pregnancy, is to find out that in the ectopic pregnancy area, which being removed for examination, include fetal parts. You know fetal parts? Fetal parts mean fetal organs or fetal component and or placental villi. So usually what we see, what we look for in ectopic pregnancy is the presence of villi, placental villi. What placental villi mean? We see trophoblastic tissue, either villi or the trophoblastic cells like the cytotrophoblast, sexual trophoblast. So that's why important for ectopic pregnancy to see the placental tissue. Risk factors for ectopic pregnancy: PID, pelvic inflammatory disease, is the most important one. Any surgery in the abdomen, surgery in the uterus, in the tube, and any tumors in the intrauterine tumors, benign or malignant tumors in the intrauterine, mainly the benign leiomyomas in the intrauterine. Smoking, it can contribute because it looks like it's, it looks like it damages the ciliated cells in the tube. That's how we explain the ectopic pregnancy related to the smoking. Congenital abnormalities in the tube, history of previous ectopic pregnancy, multiple sexual partner, devices, history of infertility, and so on. Remember that in 50% of ectopic tubal pregnancy, we cannot find any anatomic cause or evidence. So 50% of ectopic pregnancy actually are idiopathic. Ovarian pregnancy pregnancy and gestation within the abdominal cavity are extremely rare spontaneous abortion. That means we have the loss of the pregnancy in 20 weeks. Most of the time in the 20 weeks of gestation, majority of abortion happened in the first 12 weeks. So loss of the pregnancy within 20 weeks, mainly or most of the time in this time 12 weeks. We call miscarriage that occurs before the 6th week of gestation. There are some terminology like chemical pregnancy if it's done 6 weeks, clinical spontaneous pregnancy if it's done after 6 weeks, and for all of them the same thing. Just an abortion, you don't need to memorize this chemical or economic. Remember that abortion or miscarriage is very common. It's a very common entity. It's a very common problem. Remember that 10 to 25% of all pregnancy. So it's really common. 10 to 25% of all pregnancy end with miscarriage. Miscarriage being the abortion. So it's really high incidence of pregnancy and with miscarriage. Do we realize or do we confirm all of these 10 to 20%, 25% of cases? Absolutely not. Many of them just goes clinically and medically. Most of them. Because if you look at this number, it's really, really a huge percentage of pregnancy that end in miscarriage. Again, causes for spontaneous abortion, miscarriage. The major cause, this is the most important one, chromosomal abnormality. So chromosomal abnormality. The pregnancy with genetic problem has almost 100% probability to end with miscarriage or abortion. So chromosomal abnormality is so important. Hormonal problems, very important. The most common one, chromosomal abnormality, and clinically the most important clinical one actually is this one, hormonal problem. Remember that there are some diseases, entities that can end in abortion or miscarriage. Cushing syndrome, thyroid diseases, polycystic ovary syndrome, diabetes, and function of the corpus luteum and so on. Infections also is a cause for miscarriage, maternal health problem, also LA. Remember, lupus can end actually with miscarriage, lupus nephritis. Antiphospholipid antibody syndrome is very well known to end with miscarriage. Lifestyle, drug abuse, smoking, and many other bad lifestyles can end with the miscarriage. Maternal age is important, spontaneous abortion after the age of 35, it's more common than in younger age. So maternal age is important. Trauma, any trauma, that trauma can end with abortion. Anomalies, there are some anomalies in the uterus. Remember the Asherman where we have some adhesions inside, we have the septate uterus, we have the bicoordinate uterus, all of these genetic abnormalities that can end in miscarriage or abortion. So how we diagnose abortion or miscarriage? This is so important clinically, and it's a medical legal issue many times to confirm the present. Sometimes there's bleeding, there's passing of a bloody tissue, and it looks like most likely, it looks like miscarriage or abortion. And if is there most likely in this case is enough? Absolutely not. So we have to be very, very, very careful in the diagnosis of the abortion or the miscarriage. Why? It's a medical legal issue. What What does that mean? That means when we say there's an abortion, when we say that there's a miscarriage, it means we need to confirm the miscarriage or abortion, or the clinical parameters, good, important, but not enough, or the presentation, clinical presentation, not enough, the baby passing a tissue, passing a bloody tissue, bloody whatever, clots, whatever, it looks like abortion or a miscarriage. It's not enough at all. Sometimes it creates a lot of medical legal issues. So it means we need to confirm the abortion or the product of conception or the miscarriage. How we confirm it? We just examine the tissue, the past, the curative, or the past tissue. So how we confirm the presence or the pregnancy, or confirm the product of conception, of POC, product of conception? We need to find what? We need to find some in general fetal. We need to find fetal component, fetal product. Fetal, what does fetal mean? Either embryologic fetus, or parts of fetus, or what? Or this one, or the chorionic villi. You know, in 95% of the cases, more than 95% of the cases, we cannot find embryologic component, parts, or whatever. Sometimes, rarely we see it. Most of the time we don't see it. What we look for actually is the trophoblastic tissue. We look for chorionic villi. So chorionic villi is a confirmative diagnosis of the product of conception. Sometimes chorionic villi are degenerated. We look for the cytotrophoblast and cystiotrophoblastic. So in general, we look for trophoblastic tissue. Trophoblastic tissue means the chorionic villi, mean fetal parts. So this is the confirmation of the abortion. Multiple gestation of the or twin placenta, it can happen in less than 1% of pregnancy. We have fertilization of 2 ova, or 1 ova divided, or division of 1 ova. So if we have fertilization of 2 ova, then we have the dizygotic. If it's 1 ova divided, we have the monozygote. It's many forms. We have either the ones separate, we have dichorionic, we have 2 chorionic, dichorionic, diamniotic. So dichorionic, diamniotic. We see 2 chorion, 2 amnion, completely separate placenta. Sometimes we see dichorionic, diamniotic, but it fused, but still dichorionic, diamniotic. So this one is fused placenta. Sometimes we see monochorionic, 1 chorion, this is the red in color, monochorionic, but we have 2 amnions, so diamniotic, monochorionic. Rarely we can see the conjoined twins, monochorionic, monoamnionic. So it depends on how we see the twins or the placenta. The dizygotic is more common in women most of the time. Actually, the dizygotic twinning, most of the time there is a history of taking hormones, and it's common nowadays. So remember, the dizygotic twins or the twins are more common in case of hormone treatment. In this case, there's an ovulation, there's an implantation of, or we have more than 1 ova, 2 or more. So in this case, in hormonal treatment, most of the time there's a fertilization of more than 1 ova. So microscopic examination, we need to find out if we have two chorions, two amnions, and it's actually by histopathology examination we can confirm the presence of the two chorions, two amnions, and so on. Monozygotic, there's one ova being fertilized, and it goes into the monozygotic. Remember, in monozygotic, it should be genetically identical. Why? Because there's one ova divided. So genetically complete same. There are many terminology. If the fertilization happened within 2 days, if it happened from 3 to 8 days, it happened after the 8 days, and so on. Many terminology, I don't know who care about it. Preeclampsia, again, preeclampsia or toxemia of pregnancy, it's mainly a clinical entity. Preeclampsia is a systemic syndrome. It's characterized by widespread maternal endothelial dysfunction. Most of the time, it's a dysfunction in the maternal endothelium, blood vessel endothelium. This is like with the etiology of the preeclampsia. Usually, it happens within 24 to 50 weeks of gestation. Preeclampsia still some people call it still toxemia of pregnancy. So we have in these affected, we have seizure may occur in addition to the eclampsia, and the symptoms obviously determine eclampsia. So when there's a seizure, we add it called eclampsia. So preeclampsia and eclampsia still, as I said, people still call it the toxemia of pregnancy. 5 to 10% of pregnancy, so 5 to 10% of pregnancy. So hypertension, edema, proteinuria, preeclampsia. If we add to it the seizures, it's eclampsia. 5 to 10% of pregnancy. It's really high incidence of the mainly with the first pregnancy older than age 35. So a risk factor, age above 35 for the eclampsia, preeclampsia. Age above 35, first time pregnant. So hypertension, edema, proteinuria, preeclampsia. If we activate the seizure, now we have toxemia of pregnancy. Prompt therapy, it's so important to evade the consequences of the preeclampsia. The etiology, as I said, there is a problem in the endothelium. Most of the time, insufficient maternal blood flow to the problem in the endothelium, to the blood supply. What the dysfunction, what the problem in the endothelium, looks like there diffuse dysfunction, vasoconstriction, and increased vascular permeability. Complication for the preeclampsia, there are many complications. Remember the infection, hypertension, hypercoagulability status, end stage or end organ failure, sometimes the health syndrome. All of these actually complications of the preeclampsia. What we see in the morphology, in the histopathology, if we examine the placental villi in case of preeclampsia, remember we see most of the time, this is what we see infarction, so we see infarcted areas, we see hemorrhage, we see maturation for the placental villi. It looks the villi maturation in the villi looks like edematous. The vascularity is not that brisk, so hypovascularity, edema, increased production of the syncytial knot, which is crystals of trophoblast. Fibrinoid necrosis is a feature also. So these are the histopathology finding in eclampsia, preeclampsia. Remember the infarction, so important. So infarction, fibrinoid necrosis, maturation of the villi, sometimes placental hemorrhage. So 4 features. Placental hemorrhage, you see the necrosis, fibrinoid necrosis, infarction, and application for placental membrane. Fertilization, usually fertilization, one sperm, one ova, 23 chromosome, and it resolved with the 46 chromosomes. This is to prepare for gestational trophoblastic diseases. It's abnormal proliferation of the placental trophoblast. So gestational trophoblastic disease, abnormal. GTB, gestational trophoblastic, abnormal proliferation of placental trophoblast. Mostly gestational trophoblastic diseases produce the beta-HCG. Remember, beta-HCG is a production of GTB, gestational trophoblastic disease. Remember that the serum beta-HCG is also elevated in normal and ectopic pregnancy. So beta-HCG by itself is normally increased in pregnancy and ectopic pregnancy. So the presence of increased beta-HCG doesn't mean that we have gestational trophoblastic disease. It can be, but also remember that the pregnancy, ectopic pregnancy can increase beta-HCG. Most humans who have gestational trophoblastic disease can have normal pregnancy later. So with the presence of GTD, the woman can have the normal pregnancy later on. Remember, the maternal age, about 40 years, is a clear-cut risk factor for gestational trophoblastic diseases. What types of gestational trophoblastic diseases? You know, there are many types. Most of them gestational trophoblastic diseases. You know, most of them are vague, not well recognized, and most of them clinically not important. But clinically important, so all of these clinically not important. The only important gestational trophoblastic disease, remember the identity for mole, so the molar pregnancy, and the neoplasia. We'll go through the neoplasia also, what's important in the neoplasia. So the molar pregnancy is important. So all of these entities are vague, not well recognized, actually not important clinically. All of these entities. The only one you need to focus on is the molar pregnancy, and in gestational trophoblastic neoplasia, this is the most important one, the choriocarcinoma. The others also clinically not important. You know, placental site trophoblastic tumor, epithelioid trophoblastic tumor. Who has seen one of these in 50-year practice? So what's important? Molar pregnancy and the neoplasia choriocarcinoma. So we're going to the important ones and ignore all the others. The molar pregnancy is really important, clinically important, and the neoplasia and the choriocarcinoma is important. The hydatiform mole, we have partial mole or complete mole. It's very important in the hydatiform mole. Hydatiform mole is complete mole is abnormal fertilization and abnormal placenta, mainly excess of the paternal. You know, in complete molar pregnancy, all the chromosome actually are paternal, coming from the father. Most of the time in this molar pregnancy, we have what we call empty ovum. Empty ovum means there is no chromosomes coming from the female side. Most of all the chromosome coming from the paternal side. So excess of the paternal chromosome. So true, we see in complete mode, we see 46 chromosomes. If we analyze the chromosome in complete mode, we see 46 chromosomes. But all of these 46 chromosomes coming from the paternal, from the body. So remember this is important in the complete mode. 46 chromosome, but all of these chromosomes actually come from the body. How we pick up the hydrated hormone, clinically we see increased enlargement of the abdomen, increase in the pregnancy or the pregnancy age doesn't look like fits the real age of the pregnancy. It looks larger than what we expect. Sometimes we have passage of tissue fragment. Most of the time we see pain, we see abdominal distension, we do the ultrasound to see the importance of the typical ultrasound finding of the hyaluronic hormone, the extended grape-like architecture of the uterus, and the beta-HCG will be increased, clearly increased. Risk factor, we say it's important in all gestational trophoblastic disease, the age, maternal age above 35, above 40 is really important risk factor. Here, the upper age or the older age above 40 and the younger age less than 15 is a risk factor for the molar pregnancy. So the age is important. If it's less than 15, it's a risk. If it's more than 40, it's a risk factor too. Ethnic group, it's clear cut, it's very well known that molar pregnancy is really, really common in Asian ethnic groups. So the Asian ethnic group have higher incidence of molar pregnancy. Prior or previous highlighted hormone is a risk factor for molar pregnancy. So the confirmed one actually the age, the ethnic group, and the presence of previous highlighted hormone. As I said, remember we have two types. We have the complete mole and we have the partial mole. We will see how we differentiate between these partial mole or complete mole. So the complete mole, the uterus cavity is extended or dilated or getting large by the presence of these edematous chorion villi, and there is two sets, 46 chromosome, all these chromosomes, the 46 coming from the paternal side. So there is a complete lack of maternal chromosome. No maternal chromosome in the complete mole. Remember the difference between complete and partial mole, you will see that. How far the component is there. Genetically, chromosomally, it's completely different. In complete mole, we have 46 chromosome, while in partial mole, we have 69 chromosome. Usually, we have 69 chromosome in partial mole, while in the complete mole, we have 46. But all the 46 actually are paternal. So we see huge distinction in complete mole, less distinction in the partial mole. One more important issue is the presence or absence of fetus. Remember an important feature. There is no feature in complete mole. We can see fetus in partial mole. So the presence of fetus completely take out the diagnosis of complete mole. So no fetus in complete mole. We can find fetus in partial mole. So this is to explain the entities of this complete partial mole, the chromosome analysis most of the time. 46 in the complete mole, 69 in the partial mole. In the complete mole, the uterus is completely distended by the grape-like villi. These villi are edematous, very edematous. Edematous looks like grape. And if we do the ultrasound, we confirm. Another more test by serology, we check for the beta-HCG to see that. Treatment in the complete mole, just evacuate the uterus sometimes enough. Complication for the complete mole, complication sometimes bleeding, sometimes invasive mole, sometimes rarely we can see transformation into choriocarcinoma. So Choriocarcinoma can be a consequence of complete mole. Can choriocarcinoma be a consequence for partial mole? You know, almost none of the partial mole will develop into choriocarcinoma. So, complete mole, yes. Partial mole, extremely rare. Actually, nobody believes that partial mole can transform into choriocarcinoma.
In partial moles, do we also inoculate the uterus?
Yeah, of course.
With the
we
fetus?
always, we always evaluate how we diagnose it by evaluation. So in complete mole, you know, everything incomplete, exaggerated. We see huge villi edematous, you know, a lot of edema in the villi, and there is an absence of the blood vessels. In addition to the hyperplasia of the trophoblast. This is for the complete mole. What of the partial mole? In the partial mole, not all the villi are huge and edematous. So in partial mole, part of the villi are enlarged. Part of the villi are edematous. Part of the villi show hyperplasia of the trophoblast. And part of the villi show some, decreased number of the blood vessels. See the difference between the two. In complete mole, all the villi are edematous, enlarged. In partial mole, some villi. In complete mole, all the villi huge and edematous, some villi in partial mole. In complete mole, all the villi shows hyperplasia of the trophoblast. In partial mole, some villi show hyperplasia of the trophoblast. In complete mole, all the villi show loss of blood vessels. In partial mole, some villi show. See the difference is partial. Everything looks like less than the complete mole. This is the difference between the two. As I said, in the partial mole, we have three set of chromosomes. We have 69 chromosomes. One maternal and two paternal. So one maternal and two, usually three sets. Definitely one of them one maternal. So in partial mole, we see maternal, paternal chromosome. In complete mole, only maternal chromosome. 46 complete, 69 in the partial. The imperial fetal parts present in partial mole. If we see a fetal part, this is not complete mole at all. Choriocarcinoma, as we said, choriocarcinoma can develop in complete mole. Extremely rare, or actually will not develop in partial mole, the choriocarcinoma. So 69 in partial, 46 in complete mole. The uterus size, usually uterus size, remember in the complete mole, uterus size is remarkably increased. In partial mode, usually the uterus size is most of the time looks like fit the age for the pregnancy. It looks like fit the age of the pregnancy. It looks like normal in size. Sometimes it looks like even smaller than the age of the pregnancy. So the uterus was completely distended by the edematous enlarged villi in complete mode. The uterus wall is remarkably increased, while in the partial mode the uterus looks like either normal or distant. Here's the differentiation between the two. This is a good show the difference between the partial mode and complete mode. Even the beta HCG, it's markedly elevated in the complete mode. It's elevated in the partial mode. Just remember that everything is exaggerated. is complete in the complete mole. Everything is partial, this in the partial mole. Invasive mole is just a molar pregnancy that extend or infiltrate the uterus wall. It's dangerous, and many times it can cause, bleeding. So invasive mole is the consequences of molar pregnancy. The chorionic villi extend or invade the uterus wall, can cause remarkable bleeding. And many times, actually, in the invasive mole, they tend to take the whole uterus out. So they take it out to evade the extensive bleeding. Choriocarcinoma, as we said, this is the most important neoplastic entity in the trophoblastic station, trophoblastic disease. All the other entities actually are not important. Placental side, the tumor, placental side, whatever. Not important. Clinically vague, clinically not important at all. This is the important one. Choriocarcinoma is a malignant disease. It's a malignant disease. It shows biphasic. Biphasic? What biphasic? Being two component, biphasic. Biphasic proliferation of cytoplasm, syncytial trophoblast, biphasic tumor. So this is a biphasic tumor, malignant tumor, proliferation of both cytoplasm and syncytial trophoblast. It has a lot of remarkable epithelium in both cytoplasm and syncytial trophoblast. It shows a lot of necrosis. It shows a lot of hemorrhage. Sometimes you know that the choriocarcinoma is very, very aggressive. And all the tumor, it looks like necrotic because it's progressing very fast. Sometimes in choriocarcinoma we check, or we carefully check for the variable tissue. Most of the tissue is necrotic with hemorrhagic bacteria. So malignancy in the cytoplasm, syncytial trophoblast. Most of the cases, half of choriocarcinoma preceded by complete identification. So etiology for choriocarcinoma can be seen as a consequences of the identification number. Remember that rare cases of choriocarcinoma that can follow abortion, pregnancy, and choriocarcinoma can be seen in male also, where we can see testicle. So choriocarcinoma can be seen. So it's a biphasic proliferation of cytotrophoblast, biphasic mean two cell lines. Here, cytotrophoblast, syncytial trophoblast. Do you know which tumor biphasic? Do you know any biphasic tumor? There is a very famous tumor. Actually, many tumors biphasic. Teratoma more than biphasic. What's malignant tumor biphasic? We'll know. Synovial sarcoma. Synovial sarcoma, it has mesenchymal element and epithelial element. Synovial sarcoma, mesenchymal element and epithelial element. So it's biphasic choriocarcinoma. See the uterus, it's filled by necrotic hemorrhagic tissue. If we take the material, we see just a lot of necrosis and epithelium, bizarre cytotrophoblast and syncytial trophoblast. And that's all for the placental diseases. If you have any question. If you just remember what we have said today would be more than enough, please.